Acute abdomen. Differential diagnosis. Differential diagnosis: myocardial infarction, acute hepatitis, rheumatic fever, polyarteritis nodosa, acute porphyria, acute epidemic pleurodenia, acute spontaneous pneumothorax, pneumonia, pleurisy and empyema, lesions of the spine, and hip joint diseases. Myocardial infarction. Acute infarction may simulate perforated peptic ulcer or acute cholecystitis, particularly if the pain is epigastric. No abdominal rigidity, normal peristalsis, and E.C.G changes. The problem is more difficult when a patient with history of coronary artery disease develops acute cholecystitis or perforated peptic ulcer. Acute hepatitis. Sometimes there is upper right quadrant pain and tenderness initially with the disease. If suspecting acute cholecystitis, diffuse tenderness over the liver should raise the question of acute hepatitis. Differentiation is by the appropriate laboratory investigations. Rheumatic fever. It is infrequently accompanied by vague, ill-defined abdominal pain simulating appendicitis. Differentiation is done by careful history and physical examination. Polyarteritis nodosa. Many cases of vasculitis may cause abdominal pain simulating acute surgical abdominal diseases. Sometimes vasculitis may involve the appendix or small bowel. Surgery is mandatory in such conditions. It may be diagnosed on histopathological examination of the surgical specimen. In some cases, careful examination shows no evidence for a progressive intraperitoneal lesion. Establishment of the diagnosis by muscle or skin biopsy. Acute porphyria. Severe abdominal pain may occur in many forms of porphyria and porphyrinuria. Careful abdominal examination may lead to doubt on acute abdominal disease. Urine examination by Watson-Schwarz test reveals the presence of porphobilinogen. Acute epidemic pleurodenia. Particularly in young people, it may simulate acute appendicitis. It appears from time to time in children's campus. Appendectomy is done for the first few patients before knowing the nature of the disease. Careful abdominal examination is the surest way of avoiding this error. Tenderness is high and is often present over the lower thoracic wall rather than over the peritoneum. Pneumonia, pleurisy, and empyema. This or any diaphragmatic irritation caused by a thoracic lesion cause upper quadrant pain simulating abdominal conditions. Careful history plus physical examination plus X-ray studies are essential to clear the diagnosis, provided the examiners bear the possibility of thoracic disease in mind. Acute spontaneous pneumothorax. It could be mistaken for acute cholecystitis. Careful physical examination is essential. Chest X-ray is diagnostic. Addisonian crisis. Abdominal pain plus abdominal wall rigidity plus hypotension. It may be decisive of an abdominal surgical emergency. Careful history plus laboratory investigations showing low serum cortisone and low sodium, plus careful physical examination, presence of dehydration are essential. Very rapid relief on administration of cortisone and saline. Lesions of the spine. Osteoarthritis where compression of the thoracic and spinal nerves may produce severe ill-defined abdominal pain, simulating abdominal lesions, particularly biliary colic. Some degree of involuntary rigidity of the rectus muscle is an additional point of confusion. Careful analysis of the pain, nature, radiation, and hyperesthesia are differentiating factors. Radiological investigations for differentiation. A spinal cord tumor may cause radiating pain simulating biliary or renal pain. Uh, Diseases of the hip joint. They may produce pain radiating to the right or left lower quadrant. Acute bursitis in particular may simulate pelvic appendicitis. Absent true abdominal rigidity and tenderness. Hip joint examination clarifies the diagnosis. Good luck and best wishes.